Okay, we're going to start. Any question? Okay, I'm talking about respiratory distress in newborn. So newborn mean tahu newborn, boleh pas lahir kan, and respiratory distress. It's a two key issue lah. You semua dah ready dah? Semua dah ada ready? Are you already dah ada dah semua? Siapa dah? Dah, okay. So I started now. Newborn and respiratory distress, two issue here. But as usual, your respiratory distress is a symptom. Your job is to find out what is the underlying. The causes are respiratory system. We go by system first. Cardiovascular system, central nervous system, musculoskeletal, and metabolic. That is the causes. So basically, in respiratory system, you involve airway obstructions. There are many possible causes. Stenosis, clonal atresia, laryngoatresia, Pierre Robin, Walker-Cott, hemangioma. Just get to know vascular ring. They think compress the airway. Disorder of chest wall diaphragm, congenital nephrotic hernia. Disorder of chest wall. Chest wall is fixed, rigid, like June appreciated. Malformation of the mediastinum that compress the airway, that is CCAM, cyst pulmonary, or compress the airway and compress the lung. Elite syndrome, like pneumothorax, pneumomediastinum, or we call elite syndrome. Pulmonary parenchyma disorders. This is the most common. Example, like TTN, meconium aspirations, highly membrane disease, or RDS. The other common cause is cardiac. They involve cardiac syncope or asyncope. There are many causes in syncope, especially the transposition gate artery or the total endoscopic pulmonary return. Tough if bit downwards, we come to newborn. Tough, they don't cause respiratory distress much in a newborn. Asynotics, aplastic left heart syndrome, and so on. And the other one, neurological disorder, birth trauma, quite common now, and infections, HIE related to birth trauma, primary seizure disorders, and other miscellaneous, like sepsis, anemia, or polycythemia, hypothermia, hyperthermia. Hypothermia quite important. And then hyponatremia, then hypoglycemia. Another one is quite important. The metabolic problems. So looking back, it consists of respiratory system, cardiovascular system, central nervous system, musculoskeletal, and metabolic. This is the main major cause of respiratory distress in newborn. Remember that. But you see, very important when looking at respiratory distress, you have to decide if it is mild, moderate, or severe. Mild usually have tachycardia only. Moderate, there has some evidence of subcostal recession, nasopharyngeal, and that are using accessory muscle. Severe, they are sinus, grunting, drowsy, and comatose. Roughly something like this in our idea. Any patient who come, you have to assess they are mild, moderate, or severe. What are the other signs? Poor or not tolerant feeding, inactive, poor perfusion, hemodynamically unstable, having stridor or wheeze, listless, and temperature instability. Listless ni very inactive, just listless, macam tak gerak-gerak pun. That's listless mean. So basically, when it comes to respiratory distress, the treatment is still A, B, C. A means that secure the airway, either by suctions, positioning the head and the body, back and mask, intubation. Then B is blood pressure, perfusions, maintain blood pressure perfusions. C is a cardiac, and then treat the specific causes. Basically, it's that when patient come out, newborn come out, when you saw it wherever it is, either in a labor room, OT, or in SCN, or in the postnatal ward, you always look for A, B, C first. look how patient is to decide that do you need to secure the airway first or not. After that, when the patient are stable, you go back and look for the causes, the causes, as we discussed earlier. And then, in order to be able to resuscitate the children patient, you must know how to do resuscitation. This is neonatal resuscitation, newborn resuscitation. You must know how to do it. You see, the technique is not good. Why? Anybody? Because dia letak budak tu atas river, which is shouldn't. It's not a good technique. You have to put it properly at the proper setup. So talking about respiratory system, is involved a nasal cavity, then the pharynx, epiglottis, larynx, bronchus, left lung, right lung, pleura, and diaphragms, and then alveolar sacs and alveoli. This all is a respiratory system. And then respiratory system is the commonest cause of mortality and morbidity in newborn. That is fact. That is fact. Even 80% to 90% of respiratory stress mainly due to the respiratory problem. And little bit about the respiratory development growth is that they got 4 phases. It's just for interest. The phase, embryonic phase, pseudoglandular phase, canalicular phase, alveolar phase, and then alveolar phase until deliver. After that, alveolar phase when the child is outside the after the child being born, and outside the intrauterine, and then after that the size and diameter of the airway is getting bigger, and it becomes as big as adult. So basically, this is a diagram. Start for embryonic, pseudoglandular, canalicular, saccular, and alveolar. Then there is the weeks, and then this is the generation of the airway, and start bronchi, bronchioles, terminal bronchos, respiratory bronchos, alveolar ducts, and alveolar sacs. And a bit more complicated diagram. This is the phase, and then there is the major event, formation of airways, and then generation of lung periphery form, expansion of airspace, and this is where you can identify all the trace of surfactant in the amniotic fluid. And then after that, birth. Then after that is where the surfactant you start able to identify. So the first phase is organogenesis. The second phase is differentiation. So we go to the most common one first, respiratory distress syndrome. It mainly due to because surfactant deficiency. Surfactant is a phospholipid. The function is to prevent airway from collapse. The risk factor mainly is prematurity, because if you look back, here is at this 24-week and below, you are unable to detect any surfactant. So the airway cannot maintain the integrity. Here. So the time when you can detect the surfactant is at the 24-week gestation. Here. So prematurity is the main problem. Otherwise, other risk factor, male sex, perinatal asphyxia, maternal diabetes, antepartum hemorrhage, cesarean section. The diagnosis mainly by X-ray, management mostly by respiratory support, fluid, electrolyte, acid-base imbalance, antenatal steroid, and also with surfactant replacement. So the function of surfactant is to decrease the surface tension and increase the pulmonary compliance, and reduce the tendency alveoli to collapse. I think you remember this already enough. Is this because it's produced by type 2 cell, type 2 cell, and where it works is here at the interface between the fluid and the air. So it mentioned it the tension of the surface. It maintain the tension of the surface, and thus the result of it, it means it stay the integrity of the alveoli. What happen is what happen if this fluid surface is unable to you cannot you cannot sorry if it's collapsed. Well, I mean, if what happened is you unable to maintain the surface tension, the airway will collapse. You just collapse the airway, and then this is the airway, the alveoli will collapse. So this is what happens when the alveoli collapse. The lung becomes solid like a liver, very solid. This is a lung which the alveoli totally collapse, and it looks like a liver. And this is the X-ray for patients who are having LDS, hyaline membrane disease. You can see all whitish only, nothing else. All whitish, solid white, some grainy appearance at the periphery, where you can see only the air bronchogram. See the air bronchogram because everything is solid. And then treatment was to stabilize the child. Probably child you need to ventilate, intubate and ventilate, stabilize it, and then the treatment main thing is the artificial surfactants. One of this is Servanta, one of these artificial surfactant. The other causes of respiratory problem is congenital pneumonia. You know, pneumonia means infections to the parenchyma result in consolidation of alveoli, and then it's congenital, means that it occur intrauterine. The commonest is group B, Streptococcus. The other bacteria can cause Listeria, Klebsiella, but the commonest group B strep. What the risk factor? Risk factor is maternal fever, infections, maternal fever infection, the mother having UTI, chorioamnionitis, meaning inflammation of chorion tissue, premature rupture of the membrane, prematurity, colonization of mother delivery tract with group B straps, and the key treatment is antibiotics. So the transmission to the baby is either to hematogenous, ascending hematogenous from the blood from the mother blood system, or for ascending in blood from the mother genital tract, or aspiration. It means that when the child delivered through the delivery tract, the child can aspirate the infected materials. The signs: elevated respiratory rate, chest retraction, grunting, nasal flare, increase of mucus and other fluid substance in the airway, unstable body temperature, poor feeding, abdominal distension, jaundice at birth, glucose intolerance, hypoperfusion, oliguria, cyanosis of central tissue such as trunk. And then there is how the ascending will result in chorioamnionitis, and from there it goes into the babies, into embryo, into the fetus intrauterine. And then this is the chest X-ray. If you compare from the first X-ray LDS, you can observe some difference. The X-ray LDS, you see lung is solid white, whereas the X-ray in the congenital pneumonia, the lung is a bit patchy, not much solid. You can see patchy. I like to see the lung at the very solid. See the difference. See the lung is solidified. This one, the lung is bit patchy, not solidified solidly like the first X-ray. The other condition is transient tachypnea of neonatal. Is quite common, 1 to 2% of the infant that been delivered, and usually in the large preterm or in term baby, more in the term baby compared to RDS, where it mainly occur in premature. The pathophysiology is very simple. The lung during intrauterine consists only fluid, fluid only. So during delivery, what happens is that there are some fluid left inside the lung, unable to be extracted fully. So that lung result in that fluid result in the lung become wet, and heavy. What happened in the lung is patient with drowning when the water enter into the lung. So the future is they have respiratory distress. I mean that they have a tachypnea, but then intercostal tachypnea, grunting, nasal flare, intercostal subcostal recession. When you auscultate, there is crepitation. But it is a physiological process. I mean that body is still ongoing, try to absorb the extra fluid, and usually rarely persist more than 40 hours. And one of the risk factor is cesarean section, because when we cesarean section, we take out the baby quickly, so there's no compression of the lung, and the baby didn't cry so much compared to those delivered through the vaginal delivery. So cesarean section is one of the risk factors for baby to develop transient tachypnea of neonatal. Is the S3. You see the S3 is a bit different. It's more, you can see more of lung tissue, but what you can see here is the fluid in the fissure. You see fluid in the fissure there? This indicate that there is a extra fluid in the lung. The other important condition is meconium expression syndrome. Meconium is a fetal GIT secretion, fetal GIT secretion, epithelial cell and hair of the fetus. Meconium is very toxic. It can cause obstruction and inflammation of the lung tissue. We call pneumonitis. The risk factor is asphyxiated baby who don't have enough oxygen, and baby postterm baby who are more than 40 weeks, beyond the 40 weeks. The future is that there are meconium in the liquor, meconium stain on the baby, and also the baby, the infant have respiratory distress. With this, is adequate already to diagnose the child have meconium expression syndrome. Treatment-wise is prevention. Prevention of the postterm then asphyxiated, and then when the baby deliver, you have to do quite aggressive suction to prevent the meconium aspirated into the lung. And this is the meconium. You can see or not meconium, very sticky. They call whitish. This is all meconium. The other one is the big greenish, but the greenish one is more toxic. This one, the problem is very sticky. Imagine you angkat macam gum. Imagine this one stuck inside your lung. So it can cause a lot of pathology, damage to the lung if the one stuck. And the pathophysiology is quite complicated. It's just not that. It's from airway obstruction, the physics of the lung involved, alter lung elastic, inflammations, mediator was and then because of the toxic of the meconium surfactant dysfunction, voting lead into the airway, toxic of meconium constituent, probably also constitutions. There's a lot of pathophysiology, where in condition we call meconium expression syndrome. And this is the S3. You see the S3 is very much hyperinflated. You can see hyperinflated because the obstruction of the airway, and then there is a patchy consolidation, which show that the meconium that stain the lung, the parenchyma. Others pneumothorax, pleural effusion, hemorrhage, congenital abnormality of the lung, like apoplasia of the lung, sequestration, congenital diaphragmatic hernia. Anybody know what is this? Apa ni? Siapa nak try? You notice this is a lung, is it? This is a chest. This is chest. Yeah. This is the chest, and this is the. You see the lung or not? You don't see much the lung, is it? This is the heart tissue and very small lung here. It's lung here compressed. What you see is the
intestine.
Yeah, intestine, the GIT tract inside the chest, is it? This is sorry.
Hepatomegaly.
This is the liver, is it? What we call this? This is a diaphragmatic hernia because the diaphragm here unable to prevent the invaginated of the lung of the GIT tissues into the chest. This is extreme type because very bad lung hypoplasia. The lung tissue unable to develop at all, and no way this baby going to be alive. This is called diaphragmatic hernia. The failure of the diaphragms, the opening of the diaphragms result in the GIT tracts enter into the chest cavity. So from the X-ray, you can see nice here. The shadow, the air shadow belong to the GIT tracts. The lung, the heart is here, and the lung bit solid here. Some solid lung and some not very solid lung. And then it's a small diaphragmatic hernia. Diaphragmatic can be significant or just a small size. But the danger is that though it's small, it can cause strangulation. Still, you need to operate. This anybody? Notice the left lung is there is a very significant big translucency. And then you see the mediastinum is pushed to the right side and the lung here are very compressed. So this is what we call pneumothorax. This baby definitely going to have respiratory distress. Here, anybody notice any abnormality? You can see here, there is a air cavity here. It's the lung tissue. There is the heart air cavity. When you open up, it's very abnormal lung tissue. More or less air only. Nothing else. This is called congenital lobar emphysema. And you can see it compress the mediastinum, the heart to the left side and compress the lung tissue. Here, very obvious. Very large homogeneous mass here. We compress the lung. This is a bronchogenic, very large bronchogenic cyst. And not only they compress the lung, it compress also the airway, result in the child having respiratory distress. Here, anybody notice? The baby is intubated, ventilated. What you notice about the lung size?
Small.
Very
small.
Small lung, is it? You can see the heart is very big and here to here, but the lung very small. This is what we call hypoplasia of the lung. Here, anybody? This is hypoplasia of the lung. You can see that the lung is very small. This is the cardiac. You see the here, even the left lung is smaller than the heart. They call hypoplastic of the lung. This is bilateral. So the other abnormality is airway abnormality. It's not the airway. It can be airway stenosis, laryngotracheomalacia. I mean the larynx and trachea become malacid, very soft, very soft. Every time you inhale, the trachea collapse or tracheoesophageal fistula, like this one. You got cyst type. Tracheoesophageal fistula. which all this result in this is normal airway and this is fistula, result in respiratory distress mainly due to aspiration. The patient minum makan dia akan masuk dalam lung. Bila dia minum dia akan masuk dalam lung and then dia masuk sini, dia block sini, naik ke atas, masuk dalam lung balik even here the acid goes into the lung. So this is we panggil tracheoesophageal fistula, which result in also in respiratory injury to the lung and cause respiratory distress. The cardiac cause we discussed just now. There are many. Congenital heart disease, cardiac failure, myocardial myopathy, persistent fetal circulation. And the respiratory distress due because of not enough oxygenation, or it can due because of the heart failure, because of the heart failure, large VSD, or result in heart failure and the lung become pulmonary edema or wet, and then the child will develop respiratory distress. It do happen in those very obvious lung abnormality. Though it's not as common as the respiratory. The other one is the CNS. Example is spinal muscular atrophy, where this atrophy of the spinal anterior horn result in there was the failure in the nerve to initiate the muscle to contract, and the result is the muscle unable to move, and you can see like this one, patient flat, that frog-like chest is deformed, then we call it frog-like. Usually this type 1, SMA type 1. The many type SMA. The type 1, the one that you can see when the patient at the newborn. And the other type, I think we have discussed previously. The other type is like birth trauma, injury to the brain, intraventricular hemorrhage, meningitis, hypoxic ischemic encephalopathy, meaning not enough oxygen to the brain, primary seizure disorder, active hydrocephalus, infantile botulism, spinal cord injury, muscular disease. And the other type, miscellaneous, respiratory distress, sepsis, anemia, hypothermia, hyponatremia, and so on. This is the other type. So with the other condition. So what is it is that so important is that when patient come out with respiratory distress, you must able to assess the baby, the infant that come out. You must able to institute immediate management. What kind of management is necessary? If needed, you must institute immediately ventilation support, especially the airway, breathing, and circulation. Very important. In this one, you must immediately, and then after that only you treat the main cause, as we discussed previously. Okay, any other question? Hello? Yeah. Oh, go apa? Oh. Conference room kan floor. Conference room. Okay lah. Okay. Meeting lagi. Okay. Any questions? Laju sangat? Laju sangat ke?
Okay.
Slow sangat? Banyak sangat?
Okay.
Betul ke? Pacify me ya? Ke laju sangat? Simple sangat? Complicated sangat? Cukuplah, you tahu benda ni dah cukup dah, tak perlu detail sangat. That is the level you all should know. You tahu semua benda ke? Adakah orang boleh tahu semua benda? If you can remember this dah enough already. The reason I buat laju ni, I tak nak you dwell sangat tau. Some of the thing you need not to know, but you need to understand je. You all ni kalau letak semua nak tahu nanti. Nak hafal, satu slide semua nak hafal. But there's a thing we need to tell you, but you don't need to memorize. But there is thing that you need to memorize. You tengok mana yang buat laju tu tak perlu tahulah. Mana yang buat perlahan tu maksudnya I need you all to know. Boleh dapat clue tu. Ada laju saja laju tu.
Boleh.
So I don't want you try to memorize it. I tak tahu because I tak memorize, suffer nanti you all. Okay, any question? Tak ada questions? Tak ada question, habislah. Besok siapa datang besok? Buat apa tu klinik?
Group 4.
I expected you prepare one case, okay? In case I'm coming to the clinic. Okay, finish.
Okay, thank you, Prof.
Thank you, Prof.